thank you so much for coming. This turnout is unbelievable. So thank you for coming tonight, and I hope we can communicate and I can impress upon you why this is such an important condition. And Mike, thank you for spearheading this whole organization, because for 20 years I've been on my own, just spouting out what I could to anyone who was willing to listen. But I think now the world is listening, okay? So the topic of tonight's discussion is your liver, your health, and understanding the connections, which are really important, to chronic metabolic disease, and specifically metabolic liver disease. So I'm going to give you this discussion today from the viewpoint of as a physician in it and as a patient advocate. So hopefully we'll connect these scenarios. So this condition called fatty liver, like what is it? Well, as simple as the name indicates, it's when a liver looks fatty on abdominal imaging. And the most common modality of imaging people get today is an abdominal ultrasound. You complain to your doctor, I've got some abdominal pain, an ultrasound might be done that might show fatty liver. And today, globally, this is the most common cause of elevated liver enzymes. And it's present usually in people that are overweight or who are suffering from obesity. But it's also important to recognize that 10% of our patients who have even serious advanced liver disease from metabolic liver disease are considered thin. So they may look thin, but they're actually having enhanced visceral adiposity. And that's when people start to gain fat around the waistline. And I'm sure you've heard from other campaigns, especially for heart disease, when people start to carry that weight along the waistline, that's where the risks start to develop with cardiovascular risk and even increased risks of death. So it's important to understand that even ethnically, there's so much diversity in how humans are built. And there are certain ethnic communities that will have severe liver disease from fatty liver, but as I said, they look thin. And this is something we'll talk about later when it comes to waist circumferences. So we most often find out about metabolic or fatty liver disease by coincidental abdominal imaging, as I just mentioned. The next most common scenario is when you've seen your doctor and you've had liver enzymes done, and they might be a little bit elevated, and so it's noted. Sometimes nothing's done about it, sometimes it's just monitored, and sometimes more investigations are done. The other more routine way of discovering this is on insurance exams. People go to get renewals, they get more blood work done, and lo and behold, liver tests are elevated. And other people, it may be normal, but they're on certain medications. So they're being monitored as appropriately for that medication they're taking, and now liver tests are elevated. The thing that's important to recognize is that, as you've heard from Mike, more than 40% of people globally have liver fat present. And when I talk to people casually, they go, oh yeah, everyone has fatty liver. It's a normal finding. And I gotta say, stop right there. Liver fat is not a normal finding. It's not supposed to be there because fat is lipid, and lipid does not belong in your liver. And when it's in your liver, it can perpetuate disease. And that connection was not being made on a wide level until very recently. And I also have to say, when it comes to the name fatty liver, very unfortunately, many people have fallen into that category of being stigmatized. Oh, well, they must be a heavy drinker, when actually they don't drink at all. And that shuts down the conversation right there for many people. And sometimes they don't even go back to their healthcare provider because of that assumption that, oh, you must be a heavy drinker. So because of that is why there's been this whole worldwide nomenclature change that only happened a year ago. So that's how recent all of this focus has been. So the name was changed from fatty liver disease, non-alcoholic fatty liver disease, to a name that would better reflect the cause of the disease and therefore the management, and to be less stigmatizing. So non-alcoholic fatty liver disease has now been renamed Metabolic dysfunction-Associated Steatotic Liver Disease. And you can see this is what a liver biopsy would look like, nice and pink. And a normal liver is just pink liver cells, and the liver is nice and pink and smooth. MASLD is this other picture which just shows fat or lipid within the liver biopsy. And now the liver, on looking at it grossly, is enlarged and yellow, because that's the color of fat. The other name you're going to hear tonight is called MASH, or Metabolic Dysfunction-Associated Steatohepatitis, which means inflammation of the fat, when you look at the words in Latin. And if someone had a liver biopsy, this would look like inflammatory blue cells that you can see here in this picture on top or interface between the lipid. When someone has this inflammatory response, that is how progression of liver fibrosis can develop. So MASLD is just, yep, you've got liver fat, but MASH is the inflammatory, potentially progressive form of this disease that leads to advanced fibrosis, which we're going to talk about in a few more slides down. But I wanted to draw back more attention to, well, what on earth is this metabolic dysfunction that you've heard Mike talk about and me talk about? The reason we care about the word metabolic dysfunction is because it is a term that is connecting interrelated conditions that increase the risk of cardiovascular disease and metabolic disorders. That means the increased risk of a heart attack. So everyone knows what that is. Nobody wants to have a heart attack. If you have a heart attack, you hope you survive it, and you hope you never have one again. But cardiovascular outcomes mean death from heart attack or having had a heart attack or stroke. Because your blood vessels are so inflamed that you get atherosclerotic plaque formation. That plaque can move, completely occlude or clot a blood vessel, and then blood flow does not go to the tissue that needs it beyond that blockage. And that's how tissue death occurs. And in a larger form of that, as I said, is a heart attack or a stroke. That's what are familiar terms for people. So the conditions that are signaling that you are at risk of cardiovascular or cardiometabolic diseases are as follows: hypertension, high cholesterol, specifically high triglycerides, prediabetes, having already issues with obesity, polycystic ovarian syndrome, and sleep apnea. So these are all conditions that insulin resistance has already started to kick in. So why is this all developing? So it's connecting all the dots from these conditions to bad outcomes, which are the cardiovascular disease, and realizing these are all connected through, majority of people, it is lifestyle. So recurring, long-standing habits, which include malnourishment. And I call it malnourishment because it's nourishment of not the right balance of your macronutrients. And when we talk about macronutrients, we didn't really learn any of this in school. I didn't even learn any of this in medical school. So a lot of this just self-learned. But the macronutrients are as simple as your carbohydrates, your fats, and your proteins. So it's a balance of those. And an imbalance of that can lead to diseases. So food and drink are one component. Physical inactivity is another huge component. Then comes smoking and exposure to toxins like alcohol. Then there's stress and high cortisol levels and poor sleep. So if you're not sleeping well, you're not going to feel like going to the gym the next day or going for a walk or even making a nourishing meal that's a better balance of macronutrients. So when all of this is happening on an ongoing recurrent basis, metabolic dysfunction will develop. And this means that your body has lost or is losing its ability to regulate blood sugars and fats. And the liver is quite brilliant. Like, our body is really brilliant. The liver then actually creates fat out of other substrates like fructose and sugar. So for many people that have a liver filled with fat, it's not because they ate the fat. It's actually because they had a diet that was an imbalance and excessively high in the refined carbohydrates and sugars and fructose, and that just became fat in the liver through a process called de novo lipogenesis. So in the liver then, you also get hormonal changes that develop, which perpetuate weight gain and further metabolic dysfunction, leading to all the diseases that I've mentioned on the prior slides. So as you've already heard, fatty liver disease is the most common cause of liver disease worldwide. Up to a quarter of the patients who have fat in the liver will go on to have the inflammatory fibrotic form called MASH. And of the people who have MASH, 6% will go on to develop liver cirrhosis, albeit it takes a long time. About 20-30% of them, it may take up to 2 decades for that to develop. And when people have liver cirrhosis, they're at higher risk of liver cancer. But we're also realizing that even people with fatty liver disease who don't have cirrhosis are also developing liver cancer at increasing rates compared to other liver diseases. I just want to also acknowledge that there is an age difference too. So under age 50, the majority of people that are affected by fatty liver disease are men. But all of a sudden, after age 50, things change. And now it's predominantly women. And there was a recent study that pointed this out and looked at the data. So of the women who were being more diagnosed with this later on in life, this wasn't related to menopause. So realizing that menopause is a condition that leads to insulin resistance. So everyone in this room knows a woman who's probably in menopause or perimenopause. So as women get older, estrogen levels naturally drop, and when this happens, insulin resistance also starts to develop, as does visceral adiposity, weight gain, and then there's the vasomotor symptoms of menopause that can lead to poor sleep, less energy, not optimal mood sometimes, but that can also have a huge effect on, again, coming back to making a nourishing meal, wanting to exercise, wanting to do something socially with people. So it is a huge issue that's only now starting to be recognized as well. So this is a call out or call to action as well for people who are suffering from menopausal symptoms to see their healthcare provider if they are a candidate for menopause replacement therapy, because data does show treatment can also help insulin resistance, and it has many long-term benefits in terms of reducing risks of heart attack, dementia, and stroke, and even breast cancer for women. So now I'm going to shift gears to be a little bit more clinical. So this is basically the guideline that will go to physicians. So MASLD is diagnosed by having the sheer presence of liver fat plus at least one cardiometabolic risk factor. And now you understand what those are. So it's either having elevated weight, which would be calculated as a BMI, or waist circumference. And you can see, hopefully you can read it, that there's ethnic differences with waist circumference. So for example, people of European ethnicity, for women, a waist circumference of 80 centimeters or men 94 centimeters is a higher risk for having overweight. Similarly, for South Asian or Chinese, a lower measurement of 80 centimeters is there, and for 90 centimeters for men. And for Japanese ethnicity, the measurement is about 90 centimeters for women and 85 for men. So weight or obesity is one criteria. Then you move on the right is dysglycemia, or type 2 diabetes, or pre-diabetes, or somebody already on treatment for diabetes. On the bottom row is elevated triglycerides, then it's low HDL, and then the presence of hypertension. So if somebody just has these issues or they're on medications for it and they have liver fat, that is the diagnosis of metabolic liver disease. So why we care about this is I kind of already mentioned that here's the nice looking normal liver that's supposed to be pink. As soon as there's lipid deposit in the liver, that becomes MASLD when you have one cardiometabolic risk factor. And if somebody develops MASH, the inflammatory component, a significant proportion, about 6% of these, will go on to develop liver cirrhosis. And this is something we're seeing worldwide. And why, as a liver doctor, why, as a gastroenterologist, do I care about cirrhosis? That's because when someone develops advanced liver fibrosis or stage 4 fibrosis, and this is what we would see either on a FibroScan with a stiffness score more than 13 or 14, or if they had a liver biopsy. When someone develops cirrhosis, they are at risk of all of these complications below. The first one are enlarged veins in the esophagus. Those veins can spontaneously rupture, and if they do, that individual has a 50% chance of dying just from that one episode. That is a critical emergency. If they don't get to emergency or to the hospital emergency room and have an urgent endoscopic exam by someone trained like myself. The next one would be hepatorenal syndrome, which is end-stage kidney disease because of the hormonal imbalance or communication between the liver and kidney is not optimal. People then can develop fluid in their abdomen, and this is something that we start people on low sodium diets, put them on medications, and this can be a recurrent issue and can be very uncomfortable, not only for the patient, but also for the whole family. When any of these events happen, this is called liver decompensation. This individual now has a 50% chance of not living beyond 2 years. So when this happens is when I'm working up my patient for liver transplantation, and if they're not a candidate, I'm then engaging them in palliative care services. And I have a multitude of patients. I'm 53. I have patients my age that I am palliating. And that is heartbreaking to me because this is potentially a preventable condition. And that's what we're going to talk about as well. So even if someone has diagnosis on the index time of stage 1, 2, 3, or even 4 fibrosis, If it's not advanced stage 4 fibrosis, this is reversible, okay? And that's the real amazing message here. I'm hoping to get people to engage with this so that they don't develop advanced stage 4 fibrosis and then be at risk of all of these complications I've just mentioned. And also just preventative altogether and never develop liver disease. That would be amazing as well. So how do we know where someone is? Because on the outside, everyone looks fine. But how do you know if you have stage 0, 1, 2, 3, or 4 fibrosis? Well, sometimes the abdominal imaging might give a clue, whether that's an ultrasound or a CT scan or an MRI, whatever your doctor ordered. But then we also have non-invasive tests that have been available in Canada for about 10 to 15 years. Before that, we had to do liver biopsies on every single person. So that was totally not ideal. So what we use today is this FIB4 test, and this is something your primary care doctor can do. It just plugs into an app, your age, your platelet count, your ALT, and also your AST. And I'm going to mention this specifically because Ontario is one of the only provinces that no longer funds the AST by our public health labs. Every other province is covered. So if your doctor is ordering the AST, they may charge about $10 to $20 at the lab, but I encourage you to let that charge go through to get your FIB4 calculated. This is what's holding up care in Ontario for assessment of liver fibrosis. And I have written to many people about changing this, and so has Mike, and trying to see if we can overturn this ridiculous policy in this province. The next modality is through imaging, and that's the transient elastography or a FibroScan. So a FibroScan, I don't know how many of you have had a FibroScan, but it literally takes a few minutes. You just have to fast for a few hours before you test. You lie in the bed, and the little wand just is placed on your skin, and they take about an average about 10 measurements. And that will then measure the impedance of the stiffness from the wave going through your liver and bouncing back. That's what it's measuring. And one fascinating thing about FibroScan, this was actually invented in France about 20 years ago as a method to assess the density of cheese. That's what this tool is. And now it's evolved and becoming a very useful medical instrument around the world. And the benefit of transient elastography or FibroScan is, as you've heard from Mike, it will tell you your fibrosis stage, but it will also quantify what severity of fat is already in your liver, which we categorize, as you've heard, as mild, moderate, or severe. And both of those scores can improve, and they both can also worsen, okay? There's another test here called the ELF test, which is also a blood-based test, and I think Siemens is here who supplies this test, but this is not widely available. Is it at Life Labs? It is, okay. What is the cost now for it? $165. Okay, so that's also another option for you to have done at your local lab. So just to drive that message home, this is looking at liver transplant data from 2016. And the 3 most common causes of liver disease needing transplant worldwide are hepatitis C, alcohol, and metabolic liver disease. We have become awesome at treating hepatitis C. Our goal is to eradicate it from the planet by 2030 with aggressive screening and treatment with well-tolerated therapy. Alcohol is still up there, but metabolic liver disease has overtaken an indication for liver transplants. And now let's look at where Canada sits compared to the globe. So as mentioned, about 25% of the world has metabolic liver disease, and about 20-25% of them will have MASH, the inflammatory component, and 6% will have cirrhosis. Well, just look at Peel. We have 1.5 million people here. That's just under 100,000 people with advanced liver fibrosis from this condition. That is a frightening number. And so that means there's a lot of patients, like we're sitting just under 10,000 people or 8,000 that are going to have cirrhosis with liver failure coming into our hospitals, and there are not going to be enough liver organ donors, and many of them will not survive many of those episodes I just talked about when they come into the emergency room. So prevention is how I see we best have to work at this. So what are the strongest predictors of advanced fibrosis? So who is at highest at risk? Well, this is a very large trial. The NHANES data is a huge cross-sectional study that was published years ago looking at thousands and thousands of people. And the numbers show that people who have type 2 diabetes, followed by elevated BMI, followed by hypertension, are the highest risk factors for people to have progressive liver disease. That means at risk for cirrhosis. Now, I just want to show you this. So this just shows you that there's a lot of inter-body communication going on. So we have our liver, which has lipid within it, or fat, and then it goes on to develop a fibrotic liver. So what are those risk factors? Well, we kind of talked a little bit about food. We talked about, fructose, refined carbohydrates, junk food, processed food, high triglycerides, but it's also important to understand that our gut plays a big role too. The same foods that aren't good for our liver are the same foods that disrupt your microbiome. So if you're having an intake of a lot of processed food, sugary food, trust me, your gut bacteria are having a party. They're loving it. And those permeable membranes suddenly become very leaky. And that perpetuates endotoxin that goes through the circulation from the gut, through the circulation into the liver. And that will also perpetuate disease. We also need to understand that there's genetic polymorphisms. And so Mike nicely talked about, why is there so much family history of very similar related conditions? One of those issues is habits learned from our families, which were always well-meaning, but not always optimal based on the family situation. But we're also realizing there are certain genetic polymorphisms that are present in certain ethnic populations, but that affect lipid metabolism and that affect glucose metabolism. So there is something more than just eating and exercise. Part of it is genetic potential that can also play a role on who progresses more aggressively with liver fibrosis to cirrhosis. So I know this is a complicated slide. This is a slide I give at a lot of my medical talks. But where are we and how do we capture people? How do we identify who has metabolic liver disease if your own doctor isn't screening for you? So we can't screen the whole world. So it's going to be based on your risk factors. So this will be presented to primary care, endocrinologists, gastroenterologists, obesity medicine specialists. So step one is identify your patient at risk. Do they have the cardiometabolic risk factors that we've talked about? Type 2 diabetes, elevated waist circumference, high blood pressure, high triglycerides, and having liver fat on imaging. If those are present, then you also want to take your history. That means talk to your patient. Are you on any new medications? Did you see another physician? Did you go on medications? Are you drinking alcohol? That question is still important to ask, but it should never be assumed that that's what someone's doing. So ask about alcohol intake. And then the next step is to calculate the predictive score for liver fibrosis. And that's where I talked to you about the FIB-4. Getting the AST done, getting your FIB-4 calculated, which the app will then tell you. Are you low risk, meaning under a score of 1.3? Are you intermediate risk of a score of 1.3 to 2.6? Or are you high risk for advanced liver fibrosis? And if somebody falls into the intermediate or high risk, they would then technically go on to have a FibroScan. It's good to have 2 non-invasive tests to assess someone's degree of liver fibrosis. And then that'll determine who gets referred to see a specialist. Because I'm one person, I can't see the whole world, or all of Mississauga or Peel. There's only, I think, 3 hepatologists in this whole region. So if someone is low risk, they do not need referral. They need to be educated, optimized, pivot those lifestyle issues, and then repeat the FIB-4 again in a year or 2 years. The remainder of people are going to need to see someone like myself for further evaluation, ruling out other liver diseases. As you heard from Mike, there's a lot of other liver diseases that I have to deal with, but fatty liver just happens to be the most common. And then we'll discuss further strategies with that individual. So the goals of treatment are to resolve the inflammatory fibrotic component of MASH and reverse liver fibrosis. So these 2 outcomes have been the standard clinical trial outcomes in every study that's been done for the last 10, 15 years on fatty liver disease. And so you want resolution of MASH and no worsening of liver fibrosis, but you also hope for and want improvement in liver fibrosis by at least 1 stage. That means going from stage 4 to stage 3, or stage 3 to stage 2, or stage 2 to stage 1. At least that is what you want to see. And the people who've been included in all the clinical trials, who've been targeted for pharmacotherapy, have all had MASH with at least stage 2 fibrosis. So we're going to talk now about how we can reverse this. So it's been very well established that weight loss will reverse this. The trouble has been getting that lifestyle weight loss to be maintained and sustainable ongoing for life. So we know that if somebody can achieve a weight loss of just 3%, they can improve the liver fat. If they can lose 5% of the starting weight, the ballooning and inflammatory response that saw in the liver biopsy can also resolve in about 41%. If somebody can achieve a weight loss of 7%, then you will get MASH resolution in at least 2/3 of people. And if they can lose more than 10% weight loss, you will get MASH resolution and reversal of fibrosis in 45%. So this is where these weight loss targets come from. It's from all these lifestyle trials that have already been done. But when doctors say, oh, lifestyle doesn't work, it's because for many people it's not been sustainable. So I will now pivot and tell you there are treatment strategies that absolutely do work. So the first thing is moving your body. I try to do a detailed history when I talk to anybody. I want to know, do you walk? Do you move? What's your job like? Are you at a desk all day? Do you have a sitting desk? Do you have a standing desk? What do you do when you go at home? Are you driving and getting the closest parking spot, or are you walking up any stairs? When you get home, do you go for a walk after dinner, or do you go sit on the couch after dinner? So those are all the kind of questions you want to gauge to know where is somebody at with regard to their knowledge and interest in physical movement. So we know it's quite clear that the more you walk, you lower the risk of death, even if you walk under 5,000 steps. So I do encourage people to find some kind of metric that they can wear on their wrist, whether it's an Apple Watch or a Fitbit, to at least quantify how much you're moving. It's hard to make change when you don't know what you're starting with. You've all heard of 10,000 steps. That is a Japanese gimmick that was invented before the Olympics, decades ago. But funny enough, there's actually, coincidentally, a lot of truth to that. So we learn you don't have to reach 10,000 steps, but at least 5,000, 6,000, 8,000 a day we know will have huge impact by improving cardiovascular health, reducing dementia, improving osteoporosis. It reduces stress, reduces body weight, and improves muscle tone and mobility. And it also will improve blood sugar and blood pressure. So many people will get off medications by simply implementing regular walking. I also want to draw attention to muscle in our metabolic health and why this is so important. Majority of people don't realize that after the age of 35, every one of us will lose muscle mass 1 to 2% per year. And our muscle, if you don't purposely try to strengthen it, it's going to keep on declining. So it's no wonder that everyone 40, 50, 55, 60 is starting to become pre-diabetic and diabetic, because as we're losing our muscle mass, we're losing an engine of glucose metabolism. So this is not something to ignore or be taken lightly. So making a specific effort to strengthen your muscle is really important. You don't need to look like a muscle, like a bodybuilder at all, but just lifting your groceries, lifting something up, doing squats. Simple things will strengthen specific muscle groups in your body, which will hugely impact your glucose metabolism. And I also just want to mention Zone 2 training, if people don't know what this is. So Zone 2 training is a very doable type of cardiovascular fitness because you don't have to run, you don't have to be out of breath. It's like actually a conversational pace. So you're either walking briskly, putting on a weighted vest, which you can buy on Amazon for like 50 to 60 bucks, or walking on a treadmill at a 5% incline for 30 to 45 minutes. Zone 2 training keeps you below the lactate threshold and helps you gain fat loss. Not gain, wrong word to use. It helps optimize fat loss. And for a lot of people, they do want that, but it also improves cardiovascular fitness. So we all know that dietary changes and exercise are very important. We talked about exercise alone will reduce liver fat. Aerobic, meaning 150 to 250 minutes a week of moderate intensity exercise, can reduce your risks of a heart attack by almost 40%. Combine that with some form of resistance training or exercise, and there's lots of people online. You can do it for free from your home. And just simple weights, 5, 10, 15 pounds, and then slowly build up a little bit more when you can. And then when it comes to diet, we want to really encourage people to avoid fructose-sweetened beverages and added sugars. So it's crystal clear that sugar intake is connected to metabolic disease. Large studies are always lacking when it comes to nutrition, and most nutritional studies are often terrible, flawed, and biased. But what I really want to drive home is that liver fat, even without fibrosis, even if your liver enzymes are normal, It's an important finding because it's an indicator of insulin resistance, that is already in process. And I've also learned from 20 plus years working with patients that saying to somebody lose weight, which I did do in my first few years in practice, I'm like, just lose weight, I'll see you in 6 months. That doesn't work. But I have learned that trying to educate someone on the how can really be a lot more impactful. And also the message is, it's not necessary to lose weight, but I want you to improve your metabolic health. Because as you're exercising and building more muscle, your weight, in fact, may not change, and that's okay. We want the waist circumference to shrink down because that's where the cardiovascular risk is, and I want blood sugars, insulin levels, and the liver fat to slowly regress. So just to show you proof of concept, this is a slide just showing what fructose ingestion does. So if you drink a can of Coke or you have a lollipop, your body doesn't know where that fructose came from. You have swallowed it, it's gone into the gut, and as I mentioned earlier, it disrupts the gut microbiome. So you get what's called dysbiosis. And then you get bacterial endotoxins and cytokines going into the liver, causing liver inflammation. This yellow block is representing the liver cell, by the way. And then as I mentioned, you get oxidative stress, you get what DNL means is de novo lipogenesis. That is the fructose directly being converted into liver fat. And the body does this as a mechanism of converting it to a different energy form. Especially if someone's not exercising or burning that energy, your liver is just collecting it, storing it. And I kind of describe it as being a bank of energy, waiting for you to draw on that stored or savings. But if consumption continues, the liver fat bank will just keep on getting big. But it's not the kind of bank you want. It's a bad bank, okay? And then even our fat cells also become dysfunctional, and everything in the body becomes insulin resistant. So one step I'd like to do is educate people on what sugar is, because our labels in Canada are still terrible. Everything's listed in grams, and most people don't know what that means and what that looks like. So 1 sugar cube, 1 teaspoon is 4 grams. This is actually critical math to know. When you know this, you now have shopping power. You know what to buy. So the WHO made some excellent guidelines on sugar intake in 2015, which they desperately needed to do because before that, everyone was flailing around. No one knew what's high sugar, what's low sugar, what's too much for disease. But women should have no more than 6 teaspoons of sugar a day, and this is already what's in our food. Men should have no more than 9 teaspoons, and children should not have more than 3 teaspoons of sugar a day. And I'm going to show you how we have blown this. So how much sugar is being consumed? So early 1900s, the average North American was consuming 30 grams of sugar a day, which is about 7.5 teaspoons. By the mid-1970s, this went up. And do you know why it went up? Because this is when all the studies on heart disease came out and the low-fat guidelines came in. And everyone was terrified of fat. This is the margarine era. People stopped having healthy fats. Instead, they started having a lot of carbohydrates, and sugar replaced everything. So this is what happened in the 1970s. And by the mid-1990s, people are now consuming, on average, 27 teaspoons of sugar in a day. And now it's at 35 teaspoons sugar a day. And remember the guidelines? No more than 6 a day for women, 9 for men, 3 for children. So just look at these labels. A bowl of Fruit Loops will have like 12 grams of sugar. And that's the dry cereal without milk in it. So for a child, they've blown their sugar budget within 5 minutes of coming down in the morning to eat breakfast. Similarly, these things of oatmeal also have the same thing. They're sweetened already. And this one again is 13 grams of sugar. Nutella. I know this is not a good slide to put up there, but 1 tablespoon of Nutella has 11 grams of sugar. Like, how's that even possible? That's like 3 teaspoons of sugar in 1 tablespoon of Nutella. And most people don't stop at 1 tablespoon. So it's a treat. Just recognize that. It's a treat. Don't have it every day at breakfast. Fruit yogurt. And when I started asking my patients, oh yeah, I have fruit yogurt every day. I love the probiotic part of it. So I know a lot of patients will used to have Activia, but it has 18 grams of sugar in just 1. So for women, they're pretty much blowing their sugar budget with just that. Now let's talk about juice, and maybe with the tariffs, maybe Canada will be free of orange juice. This might be good, actually. Okay? But this, I put this picture up because orange juice was actually vetted by the American Heart Association, which is, it's no longer, but it has, 25 grams of sugar. Same with, chocolate milk. That's an enormous amount of sugar when you think about these types of drinks. Then you got a can of Coke, 39 grams of sugar in one can. That's almost 10 spoons. And I, in fact, saw a patient today who drank 6 Cokes a day. He had no idea. No idea. So people still don't realize what's in them. And he felt, well, if it's for sale, certainly it must be okay. But it's not realizing that he acknowledged he has an addiction to it. But that's how much sugar is in a can of Coke. And I actually did this. I wrote an article to the paper. It's actually almost 5 years ago to the day. So I started outing Tim Hortons. And listen, I enjoy Tim Hortons coffee. I'll have a dark roast black. But their double doubles are not 2 spoons of sugar. So I started interviewing my patients. So where were you getting your coffee? What are you getting in it? I started to go on the app right in front of them. So one patient had a large coffee with 2 milk, 2 sugar, and he thought it had 2 sugars in it, but it actually has almost 8 teaspoons of sugar. Okay, so a large with 3 milk, 3 sugar is 15 teaspoons of sugar. So Tim Hortons has never responded to anything that I've ever, outed them on, but this led to a whole CBC episode on Marketplace. So you can look me up. I'm on CBC Marketplace, where we went to looking at all the different coffee vendors in the GTA, looking at the sugar content of coffee drinks. So buyer beware, a double-double is not what you think. So if you're having one, someone who loves it, just educate them. And, they can go a 1/4 teaspoon and slowly just start weaning off of it, because Tim Hortons uses a pump. It's not a teaspoon. Okay, another place that people don't really realize they're getting sugar from is their bread products or their carbohydrates. So there's a concept called net carbs. I want everyone to understand this because, again, we did not learn this in school. So when you look at the back of a label, you want to get the net carbs. That means looking at the grams of the total carb minus the grams of the fiber. The fiber is the good stuff. You want high fiber. And then you subtract that and you get the net carbs. So you'll see in this is a bag of bagels. The total carbohydrate is 53 grams minus the fiber of 2 grams. So that's 51 grams net carb. And why that's important is because most people are consuming 300 grams of carbohydrate a day, and that is excessive. And the recommendations to improve metabolic health is keeping your carbohydrate intake under 100 grams. I'm sure you've all heard of a ketogenic diet that is extreme, and that's net carbs under 50 grams. I think that can be really hard for people to maintain. But I think calculate what you're consuming and try to keep it between under 100 grams a day of net carbs. And I'll show you another example. So this is Catelli Super Greens, 53 grams of carbohydrate minus 5 grams of fiber. So that bowl of pasta cooked, and that's in a 1/4 cup, by the way, will have 58 grams of net carbs. So I think a 63 minus 5. And similarly, you can calculate the same for brown rice, white rice, or quinoa. And certainly quinoa has protein in that, so that's probably a better grain to have compared to something like white rice. So moving on now to things like coffee. We just talked about coffee, but coffee is actually very good for the liver. It's good for many things in cardiometabolic health. So I won't bore you with the details of all these studies, but they found that the maximal benefit with the polyphenols from coffee came at drinking 3 to 4 cups of coffee a day. And I know that's a lot of coffee. And it's only if you tolerate it, obviously this is ideal, black or with a bit of cream, a bit of milk, but absolutely no sugar, and try to minimize sweetener as well. And the benefits of coffee were seen even with decaf, and even certain forms of tea as well, can not only improve liver disease, but can even reduce the risks of liver cancer in people who are at risk of it. Vitamin D is a very important, it's actually a hormonal vitamin. So in North America, and actually every patient I screen, pretty much everyone, I would say 85% of people that I see are vitamin D deficient. So this is a very common problem in North America. We are typically told that we will absorb it through our skin, but our skin is barely exposed for only a few months of the year. And why it's important is that vitamin D deficiency is actually vitamin D is important in the mechanism of the GLUT4 enzyme, which is a critical component of glucose metabolism. And you also need magnesium as a coenzyme with the vitamin D. So based on this and other studies that show that vitamin D supplementation can improve fatty liver disease, this to me is an easy no-brainer recommendation for me to make to everybody. So I recommend vitamin D, 2,000 units a day, and I also recommend magnesium glycinate, 200 milligrams, to help the optimization of vitamin D absorption and mechanism of action. So I'm really a big believer in trying to do as much as we can with what we have to keep ourselves healthy. And as a GI doc, we learned about all these gut hormones. And I have to say, we've done a terrible job at educating people on how to really maximize our lifestyle nutrition to allow our bodies to function normally. So you've all heard about GLP-1 and Ozempic. We make it. We actually make GLP-1. It is an enzyme that's released by our small bowel in response to food intake. It's the hormone that tells us we're full. It's one of the many hormones that tells us we're full. So it will respond, though, based on what kind of foods you're eating and consuming. So we're going to shift now and talk about timing of eating and frequency of eating, and then we're going to talk about the drugs at the end. So these are two other really important hormones, ghrelin and leptin. So this is about, does timing of eating matter? And it actually does if you are on a mission to improve your metabolic health. These are simple interventions that you can do. So we know that ghrelin is a hormone that makes you hungry. Think like ghrelin, the gremlin, the monster, it gets you hungry and angry. Whereas leptin is the hormone that tells you you're full, I've had enough. So late night eating actually makes you have a lower serum leptin the next day. So that means the signal to tell you you're full has just diminished. Similarly, if you have late night eating, your core temperature drops. That means your energy expenditure drops the next day. And that also affects fat or lipid gene expression also the next day. So late night eating is, if you have an option, try to minimize it. Because late night eating has been shown in science to make people hungrier the next day, less physically active the next day, and also if you're tired, people tend to choose comfort foods and not necessarily the more nutritious ones. So that's one tip. Does food macronutrient sequence matter? Yes, it does. So again, simple things if you're trying to make a change. So this is studies looking at, did you start with your carb, your fiber, and then your protein, and what order matters? And the one that showed the best improvement was having the carbohydrate at the end of your meal. So start your meal with your salad or your vegetables, then have your protein, and then have your carbohydrate at the end. For people who wear a continuous glucose monitor or are diabetic, they will notice less spikes in their post-meal blood sugar by eating in this way. Intermittent fasting. So you've heard Mike talk about this as well, and the way I look at this, this is just another tool in the toolkit. It is not starvation, it is voluntary ways of optimizing when your eating windows are. So the most common you'll hear about is called 16 and 8, and that means you're fasting for 16 hours and eating in an 8-hour window. So for most people that aren't shift workers, they will typically eat from noon to 8 p.m. and fast the rest of the time. Water is fine. Make sure you have a good serving of a healthy fat like Greek yogurt at dinner, just to kind of help with that satiation and keeping you full. Because having healthy fats and proteins and fiber actually make people eat less, and they make you feel full a little quicker. So with regards to intermittent fasting, how it works is, remember I mentioned the liver is a bank of fat, it's a bank of energy, but if you keep on making deposits, it just gets bigger and bigger and bigger. So this is how fasting can actually be impactful. If you're no longer feeding the bank, well, your cells need energy. They need a little bit of that. So now when your hunger cues go up, don't eat, ignore it, but your cells will now convert, your liver will convert that stored energy from fat back into usable energy, and that will power your cells. You will not die by fasting for 14 or 16 hours. You might be a little bit grumpy the first few days. It takes about 5 days to get to adapt and get used to intermittent fasting. Other benefits have been shown that it improves, it might slow aging, it can improve oxidative stress, it can improve memory, it certainly gets away from that post-meal fatigue that many people have. So the one thing that I would prioritize is that when you are breaking your fast, that you do it well. So you prioritize protein, at least 30 grams a meal, and make sure you're getting enough fiber. So don't ruin your fast by going and having a bagel. That will not serve you well. So I hope I've impressed upon you like what you can do with the weight loss or your lifestyle. So the goals of the weight loss, as you know, are to achieve 7 to 10%, because that's what we know from the data will resolve fatty liver disease, the inflammatory component and the fibrosis component. It is possible long-term to sustain this if people have the tools and resources to know how. And if not, we have other tools, which I'm not going to go into tonight, but like bariatric surgery and improving waist circumference is the goal. So first thing, reducing fructose, sugar intake is huge, minimizing alcohol. We've talked about the macronutrients, minimizing refined carbohydrates and processed food. Call it whatever diet you want, Mediterranean, low carb, as long as it's real food. That's the most important part. And you can combine with that intermittent fasting. We've talked about vitamin D. We've talked about avoiding late night eating. And we've also talked about dietary sequencing, how that matters. Sleep, super important. If you don't get good sleep, it's important to get screened for sleep apnea, because that could be contributing to poor sleep and poor activity and weight gain and even cardiac risk. And again, I can't stress enough the importance of physical activity and coffee consumption. If there's no limitations on tolerance, go for coffee. It's very helpful. So let's come back to now the real world. You're in the healthcare provider's office and a fatty liver is seen on your imaging and your lab test may or may not be elevated. The doctor or a healthcare provider will ask you, they should ask you, are you taking any supplements? Are you on any medications? Alcohol, travel, lifestyle, any infection risks? Is there any change in your energy, joint pain, energy level, yellow eyes? And all those questions are relevant because they're trying to figure out what's causing this. Even though we know that fatty liver is the most common, this is still important questions to ask. The healthcare provider should hopefully screen for viral hepatitis if you don't have that documented in your chart. Do an ultrasound if it's not done. Order an AST and calculate your FIB4 score, and then make a decision with you on whether or not you want further investigation with a specialist and get a fiber scan. So we're going to shift gears and talk about pharmacotherapy, and I left this to the end because I don't have anything to prescribe in Canada yet, but we will. I'm hopeful about that. But you heard me talk earlier about what are the endpoints of pharmacotherapy. It's been MASH resolution and improvement of fibrosis. There has been no clinical trial that met those endpoints until the end of 2024. And these are the three drugs we're going to talk about. Semaglutide, which you know is Ozempic, resmetirom, which is also called Resdifra, which you've heard Mike talk about it. They have not yet applied for approval in Canada. And then tirzepatide, which you've heard about as Mounjaro. So I'm not going to go into all the data, but semaglutide has shown to be an absolutely amazing drug. It's mimicking what we already have in our bodies, which is GLP-1 analog. And it's been shown to not only improve hemoglobin A1C, improve insulin sensitivity, improve diabetes control, it has shown that it can reduce people's weight for people who are suffering from obesity, and that weight loss can be maintained while they're on the medication. I'm going to bypass MASH here and just talk about cardiovascular disease. So we also know that people taking Ozempic had a 20% risk reduction in a major adverse cardiovascular event. People who had heart disease had less admissions to hospital for heart failure. So Ozempic has multiple roles in the body which have been hugely impactful. And now when it comes to the liver, there was a trial that was published in 2020 that again showed failed drug. But us liver specialists knew the biggest flaw. It was only a 1-year study. You cannot reverse liver fibrosis in 1 year. So the 5-year trial called the Essence trial is ongoing right now. And the 72-week data was just released in September. And it showed that it's working. So it helps the liver as well. And in fact, they showed that by week 72, 37% of patients had resolution of MASH, and 63% by week 72 had improvement of liver fibrosis. And this is a 5-year study. So already week 72, there's been very exciting data. So in Canada, I, as a liver specialist, cannot still prescribe this because it would be considered off-label for me. But if somebody, I always put it in my notes to people's doctors, if you meet criteria for obesity, for diabetes, you have heart disease, talk to your healthcare provider and think about getting on a GLP-1 drug. Yes, there might be some side effects, but the majority of people can definitely manage these side effects. Just a quick slide on tirzepatide, which is called Mounjaro. This is actually a screenshot from the New England Journal where it was published just this past June. And this is a similar drug to Ozempic, but so it's Ozempic plus another drug. And they work by maximizing insulin secretion, improving insulin sensitivity, and reducing your blood sugar. And very similar data to Ozempic. I'll just draw you to the big blue bar, which is again like a 62% improvement in MASH resolution after this study was 52 weeks. So they showed it even a shorter time than Ozempic did, but it's probably because they had that second drug attached to it. And then there's resmetirom that's made by Madrigal. So this drug is the first drug approved for treatment of MASH. It is available by prescription in the United States today. This just became available a few months ago. And it showed data that's not as amazing as the GLP-1s, but it did show MASH resolution at the highest dose of 30% and also fibrosis improvement in 24%. So even those numbers still don't look as good as the 72-week data from Ozempic, but it's still amazing to see. And we're, as Mike said, we're petitioning our bodies in Canada to get this approved. But there's also trials looking to combine them. So I think there's a lot of exciting things that are coming ahead. We're looking at a GLP-1 plus a drug like resmetirom, which works through a completely different pathway to not only achieve MASH resolution, but also to allow people to have the weight loss that we know will improve all of those cardiometabolic risk factors and outcomes that we've discussed. So we're at the end. Thank you for all your patience. So I hope I've driven home the message here that type 2 diabetes, obesity, hypertension are the strongest predictors for someone to have progressive advanced fibrosis. And this affects about 25% or 40%, of the globe. And 6% are risk of getting cirrhosis and its complications. And just to realize, it means you have insulin resistance for the majority of patients. There's still a 10% that is caused by something else, which your doctor should rule out, but majority, it's insulin resistance. And prioritizing nutrition, moving your body, and the goal is to reduce the liver fat because it's not supposed to be there. And as I've already mentioned, we're waiting for Canadian approval for some of these drugs. And just to know that the FIB4 is an important test that you could have access to by predicting what your fibrosis score with a simple blood test with your healthcare provider. And anybody with advanced fibrosis or moderate to advanced fibrosis should be referred to a GI or liver specialist for treatment of this. But other patients that we see also are just abnormal liver enzymes that we don't know yet, and they still warrant investigation to make sure we're not missing other very treatable conditions. And that's it. Thank you for your attention.